Greetings, and welcome to the first webinar sponsored by the Center for Bioethics and Human Dignity as part of the Center's Healthcare Ethics Council. My name is Michael Sleesman. I'm the Managing Director and Research Scholar for the Center. Before we begin today's webinar, I just wanted to briefly introduce you to the broader work of our center. The Center for Bioethics and Human Dignity, or CBHD for short, is a Christian bioethics research center at Trinity International University that explores the nexus of biomedicine, biotechnology, and our common humanity through a distinct commitment to the Judeo-Christian worldview and the wealth of the Hippocratic tradition. CBHD is part of a broader emphasis in bioethics at Trinity International University, known as Bioethics at Trinity, that also includes degree program options in bioethics offered through Trinity Graduate School. To learn more about the work of the center, some of our other initiatives like our Healthcare Ethics Council, to access our online resources, or to learn more about our relationship with Trinity International University and the Bioethics degree program, please visit our website at cbhd.org. Now I'd like to introduce our moderator for today's discussion, Dr. Shane Onnerecker. Dr. Onnerecker was recently appointed as co-chair of the Center's Healthcare Ethics Council, joining Drs. Robert Orr and Ferdinand Yates in the leadership of this important community of influence. Dr. Onnerecker is Chief of Aerospace Medicine for the U.S. Air Force Reserves and Program Director for the St. Anthony Family Medicine Residency Program in Oklahoma City. In addition to his medical training through Oral Roberts University, he also has a master's degree in bioethics from Trinity International University and now serves as an adjunct instructor teaching courses in clinical ethics for Trinity's program. So we are pleased to welcome him as the moderator for today's webinar. Dr. Onnerecker?
Thank you, Dr. Sleesman. Thank you so much for the efforts you continue to put into making the Center for Bioethics and Human Dignity such a worthwhile and effective organization. Also, I appreciate Jennifer McVeigh and Glory Diaz for all of the hard work they've done to make this webinar possible. Before I introduce our speaker, I want to say a brief word about the Healthcare Ethics Council, the HEC. If you've attended the HEC meeting during the CBHD annual summer conference, you know that we have a large and very active group of professionals on our council, and we're growing every year. We have nurses, physicians, ethicists, chaplains, and other educators who are enthusiastically engaged with the ethics issues of our day. Our members are teaching in churches, high schools, colleges, graduate programs, medical schools, residencies, and academic institutions around the world. We're at the bedside, on numerous local, regional, and national committees, and in the halls of leadership, talking with politicians and healthcare planners and decision makers, bringing a Judeo-Christian perspective to the enormous ethical challenges in healthcare. And what we want to do as we move into 2015 is bring this group of talented men and women, separated geographically, closer together. We can learn from each other, help each other, and work together to make a difference in our culture. In the next few weeks, you will hear more about our ideas for taking the HEC to the next level. I believe you'll be excited to be a part of this important venture, so stay tuned. Now let's get to what we all tuned in for. Here's how the webinar will work. For the next 30 minutes or so, Dr. Nash will speak, and during that time, you should jot down questions you would like to ask Dr. Nash. At the end of his talk, a Q&A box will open up, and you can type in your questions there. Then I will present your questions to Dr. Nash, who will respond to as many of them as he can during the time we have left. Dr. Ryan R. Nash is the director of the Ohio State University Center for Bioethics and Medical Humanities. He's an associate professor of medicine and holds the Hagop Mekhjian Chair in Medical Ethics and Professionalism at the College of Medicine. He received his medical degree from the University of Texas Medical School at Houston and his master's degree in bioethics from Trinity International University. He completed an internal medicine residency at the University of Texas Medical School, a fellowship in palliative medicine at the University of Alabama School of Medicine, and was a fellow and visiting scholar at the McLean Center for Clinical Medical Ethics at the University of Chicago's Pritzker School of Medicine. In addition to practicing palliative medicine, Dr. Nash is a clinical bioethics consultant and healthcare ethics advisor for the OSU Medical Center. He serves on editorial boards of the Journal of Medicine and Philosophy and Christian Bioethics. He's published 1 book, 3 book chapters, and several essays related to bioethics, and has presented numerous scientific papers and invited lectures at national and international meetings. Dr. Nash currently serves on the Ethics Committee for the American Academy of Hospice and Palliative Medicine and is an adjunct professor of bioethics at Trinity Graduate School, Trinity International University. Dr. Nash?
Great, thank you, Shane. It's a great honor to be asked to give this talk and to kick off an exciting program with CBHD and my friends there. Thank you all, and thank you all for tuning in. I hope this will be a fruitful time. What I'm going to do, and I'll change the blaze here to give the Ohio State colors. What we're going to go over is a brief historical overview of Ebola, why we should care, and then go over some of the ethical considerations that are listed on the slide here. What this talk is not going to be is it's not going to be a talk that gives the great depth and scope of specific ethical considerations. I'm also not going to review all the literature that's quickly coming out on Ebola ethics. What I'm going to really be sharing is, frankly, what I've been engaged in at the Ohio State Medical Center, which is trying on the ground as a healthcare advisor, healthcare ethics advisor for a medical center, what we've grappled with as far as policy formation and responding to some specific patient care and public needs. So this hopefully will be practical for those of you that sit on ethics committees or are engaged in hospital administration in any way. And I don't pretend to have all the answers so sometimes I'll be presenting quandaries that, of course, you may have a better answer than I do. But I'll try to hit the high points that I think we should all be concerned about. So after a brief couple of slides on Ebola in general and the current rise of Ebola, we'll be considering the ethical considerations. For instance, who will provide care for a patient with Ebola? Should there be limitations on technology or treatment for patients with Ebola? Are there limitations on patient autonomy? And one of the concerns that often arise in the ethics committee. Screening and other balancing this idea of public education and screening and notification versus causing panic. Then other considerations such as quarantining healthcare workers, quarantining other people in the public that aren't healthcare workers, and then the use of unapproved or experimental treatments, and then a larger societal question of pharma and justice issues. So to give a brief overview of Ebola, which most of you probably already know, Ebola is an acute infection. It starts as a non-specific febrile illness, can seem a lot like a common cold or the flu. It does have a fever. It's usually greater than 100.4, but usually much higher than that. Has symptoms of headache, muscle pain, malaise, progressive GI symptoms, but could start just as nausea. Symptoms usually occur 2 to 21 days after exposure, with the usual being around 10 days. Significant dehydration, electrolyte disturbances are manifest. This is increasingly aware as we're treating more patients in the U.S. and these electrolyte disturbances are being, and in Europe, and as these electrolyte disturbances are being tracked. It causes small vessel involvement and multi-system organ failure, and hemorrhaging, which is one of the reasons it causes such panic, is this is a dramatic death, and so hemorrhaging can accompany after the second week of illness. Very poor prognosis is associated when a patient has shock, encephalopathy, or extensive hemorrhage. However, there's limited experience with advanced medical technology. because most of the clinical experience with Ebola is in Africa, where there are limitations to the availability of some medical technology. Just as a historical perspective, there's the family of the virus. It is an RNA virus. There's there's 5 subtypes, and they do behave somewhat differently. There's no current vaccine, and there's no approved treatments, though, as you know, following the media on Ebola, there are treatments that are under testing and several in the pipeline, including vaccines in the pipeline. The case fatality rates of up to 90% in African settings. This depends on the year and the outbreak and the subtype. These are some of those years and outbreaks. So when you have the Zaire virus in 1976, we had up to 88% mortality. And you can see a range of 53 to 88% in these different outbreaks at different times. So the current Ebola virus disease epidemic is focused in West Africa. It's been limited to Guinea, Liberia, Sierra Leone, and a few other countries. Senegal and Nigeria had small cases, mainly from border crossings, but no longer have current cases that I know of since August and September, respectively. These data, the cases and deaths, I last updated in October, so these are a month or a month and a half out of date. In early August, we had our first healthcare worker brought from West Africa to Emory University, which caused a great deal of caused a bit of a media frenzy and lots of speculation on why we would want someone with Ebola to be brought into the country. Other individuals since there have been brought from West Africa for treatment to Emory and to Nebraska mainly, but some others have come. In September 30th, the first case diagnosed in the U.S. If you consider Texas part of the U.S., this is coming from a native Texan, then the first case of Ebola diagnosed in the U.S. was famously reported of a Liberian man who had traveled to the U.S. That patient died on October 8th of 2014, shortly after his diagnosis and treatment. And as you know, 2 nurses at that Dallas hospital tested positive for Ebola shortly after his death. The second nurse had traveled to northeastern Ohio and was there from the 10th of October until the 13th of October. This included plane travel to Cleveland and a drive and attending a family reunion in the Toledo area. This heightened the concern in Ohio and caused some degree of panic, and we had some false reports or some reports of concern over Ebola infection even at the Ohio State. But it brought us, our team was, we had a honed focus due to this coming close to home. So over 100 people in northeastern Ohio were on quarantine. It should be quarantine here. I have quarantine and isolation. I'll speak a little bit. I'll make a distinction between those a little bit later. Or we're monitoring temperatures. They were either on the flight or they were close contacts. Both nurses recovered, and no further spread of the disease has been identified from this Dallas case. Other cases have been well documented. For time's sake, I won't go through them, but I mentioned this partly to say why Ohio, why I was involved. So the risk points that became clear, that have become clear over practice, observation in Africa and in the U.S. So what heightens risks for healthcare workers are exposure to body fluids during patient care, especially diarrhea and blood. One of the manifestations is a profuse diarrhea, so this has been known. Even contamination from trying to dispose of liquid waste and solid waste in toilets is a known risk. from error in taking off personal protection equipment or not having it on correctly. And then there's probably an increased risk with certain procedures, such as intubation, where there may be aerosolization or increased exposure to body fluids. So to get to the ethics of the matter, just to give you a little sense of urgency, I want you to imagine that you're the ethics consultant on call, that you're the ethics committee chair, so you don't have any backup to call, you're it. And you're paged and told that a 22-year-old college student has just returned from Christmas break, a Christmas break trip to visit family in Sierra Leone. She has a fever of 101, muscle aches, fatigue, and nausea. She's called in advance to warn the ER she's on her way. What do you do? Well, this happened. Not exactly this case, but a case similar to this happened. It turned out to be a false alarm, but these cases can be expected. At the Ohio State, where we have nearly 70,000 students, we know we have many that are from Western Africa. We have many faculty from Western Africa, and we're thinking, yes, we will have some that travel back to West Africa during the Christmas holidays, and this is a case that we may anticipate. So the hospital administration will want your help in sorting through the ethical issues. And I would say that it's better to do this in advance and have written policy and guidelines than to try to quickly go through the data and the written opinions in the literature. So hopefully this will prepare. These are some of the things that we went through as we developed policy at the Ohio State and our regional consortium. So who cares? So this is talking about the provision of care is one of the questions. Who should get this patient? Should you call her back and say, no, don't come here? Should we direct them all to the CDC or have a giant Ebola hospital? So one question could be, are you in a regional hospital or a large medical center? Should a regional hospital just stabilize and send on to the tertiary or quaternary care medical center? So the challenges of this is the more people exposed to the virus, the greater risk of transmission there is. So if you have someone in a regional hospital that's you suspect of Ebola and already has exposed certain caregivers, do you contain them and isolate them there and have those caregivers continue care for them to limit exposure, or do you go ahead and transfer to the higher level of care, high level of service and technology at a large medical center? So we know that the transfer is going to potentially increase exposure. This is a risk. So one of the next question may be, do patients get better care at large medical centers? Well, the data on these are hard, but you can say potentially there may be an advantage for an Ebola patient, since it's a rare disease, to have access to infectious disease specialists and to have clear, nice lines of communication with state authorities and with researchers and other aspects. It may be that large medical centers are a bit more prepared. That's not evident, but it's potential. So in the, it seems that there may be a favored status for larger medical centers. So in the event of an outbreak, another question may be, should one hospital take them all, again, to limit exposure, or should many? Another question could be, is there a duty for a public hospital, since it's publicly funded, do they have to rise to a higher standard than a private hospital? The same could be asked about faith-based institutions or with for-profit or not-for-profit. So one of the unfortunate, we could probably easily say, oh, the ethical duty of treatment should be this, but one of the realities we must deal with is the stigma. So there's a real stigma reality in the business practice of medicine. What was realized both at Emory and in Dallas is after the media announced that there was an Ebola patient there, number of patients decreased in both hospitals, even at Emory. It drastically decreased in the Dallas case. And a small decrease in patient flow makes a large financial difference. especially at academic medical centers and especially at specialty hospitals such as cancer centers. With their DRG exemption, a small change in patient population makes a big financial change. So there's a lot of unintended consequences there. I can say what we devised in Central Ohio is that the Ohio State Medical Center, we're going to take the first 5 adult patients. Nationwide Children's would take the next 5, or would take the first 5 pediatric cases. After those first 5 adult cases, then there will be a sharing between the other 2 large systems that also have tertiary care centers in Central Ohio. That's the ideal. We don't know if that, obviously if there's beyond 15 patients in the area, we would have to devise something different. So who cares once they're in the hospital, the provision of care? Volunteerism is the formation of teams in advance that the healthcare workers, the physicians, nurses, and everyone needed to provide care, predicted to provide care for an Ebola patient, volunteer in advance. That's the way most systems are going currently, and the way that I've advocated for our system, and the way we have done it. There's a benefit in that you have focused training of a select few on really the best practices of caring for patients with Ebola, including practice on how to don the personal protective equipment that is so critical, especially as patients get sicker. There's also, I should say, there's been impressive success in formation of these teams. We didn't even announce the formation of the team, and we had 80 volunteers just by word of mouth. And that included a full physician team, full nursing team, respiratory therapist, everyone that we would need potentially. So there is an ongoing burden of keeping these teams intact, keeping their training up to date, and this burden will increase as the duration of the outbreak increases. And of course, if there's a large outbreak, if we start having, instead of 1 or 2 cases, we have many cases, the pool of volunteers may be exhausted. Then what do we do? If it comes to this kind of point and you exhaust volunteer pools, do we honor the refusals to provide care? This is somewhat historically conformed by previous refusals in the U.S. to care for patients with HIV/AIDS. Though those may have had other valuations, some people may have refused based on discrimination because of someone's sexual orientation or drug abuse or something like this. In the early days of HIV/AIDS, it seemed to be largely refusals based on uncertainty of the disease and fear of contracting it. So with Ebola, we would have a similar concern. I do think I wouldn't want someone caring for me that doesn't want to care for me. So I think as long as we can use volunteerism, it's a good way forward. And I think this is a webinar for CBHD. I'll mention that Rodney Stark, in his book on the spread of Christianity in the early age of the church, mentions that the Christians being willing to stay put and care for those sick with plague really gave faithful witness to caring for the least of these. So I think there may be a special role for Christians in volunteering, not that all must, not that it's obligatory. So in a clinic setting, an outpatient setting, you have less control over the ability to refuse or volunteer. The patient's in front of you, they're in your clinic. So protocols are needed still to ensure that you can have effective transition to the hospital. So once you have the patient in your hospital, are there limitations to what technology or treatment may be utilized? So we know that there's very poor prognosis once a patient with Ebola has shock or multi-system organ failure. But like I said earlier, these data are largely based on the African experience, where the advanced technologies are limited. So we wonder, could advanced technologies and treatments improve survival? So if we're limiting up front in policy and guideline the use of advanced technology and treatment, are we creating a self-fulfilling prophecy to perpetuate low survival rates? We have seen this in other patient populations. I'll refer you to Bill Meadows' work on neonates for the self-fulfilling prophecy. So but we do know that even in the limited experience in the U.S. and Europe, if someone develops shock and multi-system organ failure from Ebola, their prognosis still seems to be poor, though the sample size is very small. We also do know that the exposure risk does increase dramatically as a patient worsens and the viral load increases. So we also know that certain use of technologies and procedures will probably increase the likelihood of exposure, such as intubation, hemodialysis, surgery, particularly ECMO use, and ACLS protocol. So how do we decide when this balance between the potential benefit and the risks? So I first say that I encourage the formation of Ebola response teams, and I've encouraged, and we have, I'm a member of the Ohio State Ebola response team, so having a clinical bioethicist as a member of that team I think is helpful to help grapple with these things real time. In our guideline, we have a team huddle every day, actually twice a day, if we have an Ebola patient. And the team huddle is just the response team getting together. We are continually staying up to date on the data and best prognostication treatment data, and to make particularized dynamic decisions for patients and for persons and their family, I think would be the goal. So I don't want to make any hard and fast rules on what technologies should be limited and what shouldn't. As we learn more in this dynamic decision, keeping things dynamic I think is a good thing. But having someone with ethics training as a member of the response team I think is essential. So you could, as a team, use something like a general guiding, for those that are visual or mathematic thinkers. Sorry, the E in life is cut off here on this formula. This is from Englehart's Foundation of Bioethics. It's just saying that the duty to act in beneficence, the duty to help, render aid, is equal to the chance of success times the quality of life times the length of life over the costs or risks. Now, Englehart's not saying this is the way it should be. He's just saying this is how it could be. And I think it's good to know that we do take risk into account. If you take even in battlefield situations, if you know the machine gunist is still trying to mow you down, well, how you can render aid to the injured soldier may be limited if you're putting yourself at harm and your whole team. So the risk of exposure to other healthcare workers can factor into this. And I think, especially when it comes to ACLS, if someone requires CPR that is dying from Ebola, their prognosis may be so poor that it reaches physiologic futility, and not employing that seems reasonable to me, since it would, I think, greatly increase the likelihood of exposure. Where else to draw the line, I don't know. It depends on the case. So the great ethics challenge is uncertainty. As you know, anyone who does clinical ethics knows that that is the reason there is a such thing as medical ethics. If we were certain on the outcomes, then we wouldn't have many dilemmas. So some other considerations for caring for patients with Ebola once they're in the hospital is that those of you that use the 4 principles, which I often deride as not very helpful, but it's at least in our nomenclature, I should address it. We do have limitations on patient autonomy. The patient has to be isolated. They don't have a choice on that. Matter of fact, most of our patients that require isolation don't have a choice on whether they're isolated or not. We even may restrain them if they try to become unisolated. There would be restrictions on visitation. This is at a time in medicine where we're trying to have more open access ICUs, but we would not allow visitors in the least normal sense of going into the room on a regular basis. We may not allow them in the room at all, and they may be able to see someone from outside the window. And that isolation, that level of isolation without visitation of loved ones is a very powerful thing. It affects health. We should know that it has potentially negative consequences as well. So non-adherence to medical advice, to medical treatment. I think we would probably limit that. This disease is that severe, and the risk, the public health risk, may outweigh at times the potential of non-adherence. Leaving AMA would be unthinkable, right? We would physically restrain a patient, use law enforcement to keep them in a hospital if they were trying to leave with a known Ebola infection. So we probably couldn't honor requests for transfer. We probably couldn't honor requests for change in healthcare team members. Demands for treatment would have to be weighed with whether they're effective, available, so they may not be honored. And then treatment refusals, it depends on what is refusing. So if someone requests, no, I want to have a do not resuscitate order, that is probably a treatment refusal we would honor. Other treatment refusals may not be as possible. So one of the other dilemmas is, how do you balance the public concern without invoking panic, but having an appropriate response? So we know that rapid response and patient identification are critical for disease treatment and containment. So the risks of public education and screening modalities are that you can bring public panic and false alarms, and there is a burden of screening. The false alarms aren't necessarily a bad thing. Having people with travel history or potential exposure that have the flu or some other virus, having them screened, that should be seen as an effective policy if you have false alarms. Inducing panic where everyone who has the flu thinks they have Ebola, even though they haven't had any travel or contacts, is a great concern. Then this burden of screening. I remember going to the hospital with my wife as she was going, as she had healthy pregnancies, and we were going to deliver, and being asked horrific questions about whether we wanted to have a do not resuscitate order and wanted a living will. It just seems inappropriate to ask that of healthy pregnant women. And I think we want to be aware that there is a burden to screening. As a woman's in labor, that's probably not the best time to ask her about resuscitation. But what can we do for Ebola? Well, I think a simple screening is reasonable. So at Ohio State, we have 3 simple questions, and we're asking all outpatients and all inpatients as a simple screening. Basically, have you had any travel or known Ebola contacts? Have you had these certain symptoms? I mean, those simple, reasonable questions, and it is being tracked on all of our records. I don't think it's overly burdensome for the patient, though it may become so over time. Especially if you have repeated encounters and having, imagine if someone has 10 office visits in a month, which isn't uncommon, being asked about Ebola every time may become burdensome. So to the next, I don't know why I have a blank slide. Sorry about that. To the next potential issue is more of a systems issue. What do you do with your own employees in your system that have gone to have service mission to West Africa? Should healthcare workers traveling to at-risk regions be quarantined? Should there be a distinction to those that have gone to service mission and have had known exposure to disease, or those that are traveling for other support, such as infrastructure building? I know someone here in Columbus has gone to help build a good sanitary waste system. They don't have known exposure, though they are in a region with infected residents. We have faculty, like I mentioned, and staff that have family that live in West Africa and have visited them recently. So now we have to deal with the real risk, which we know with Ebola the likelihood of transmission is very low unless someone manifests disease, fever, and other symptoms. And we've realized this even in the U.S. experience, notably those two nurses I mentioned, or the physician in New York, the family member of the patient in Dallas. These casual contacts before symptoms did not contract the disease. So there may be a distinction between these, but we have to realize the real risk and the PR risk. Both, when we make policy and guidelines, have to be taken into account. So imagine if you're a patient and you have a nurse from Sierra Leone or Liberia and who just starts chatting with you about her recent trip. Would you feel a sense of trust in the time of your illness? This is important. I think we can educate through this potentially, that maybe that nurse or that physician is taking their temperature twice a day and may not need to be quarantined, but there may be a real uncontrolled, you can only educate through so much, and it's not clear that the education will be effective. So it may be reasonable to have a voluntary or mandatory reporting, and even not having people that have traveled or had known exposure come to provide clinical services. So one of these is because there is an absolute disaster for any, for this again, thinking of the business practice of medicine, there's a disaster if patients infected become infected in a hospital or a clinic by a healthcare worker. It's very clear that there'd be a lot of retrospective blame and that more stringent occurrences should be happening. Many of the articles that are currently being written, including one in New England Journal, saying that we shouldn't quarantine. I don't know if the public quite trusts that, because if you remember, with the first cases being brought to Emory, the likelihood of transmission was 0, and then we had the Dallas case. Even when the Dallas case was known, the likelihood of transmission was said to be 0 by some leaders. So that quarantine shouldn't be used, I don't think there's quite public trust for yet. So one of the concerns is if you do quarantine healthcare workers, would you be discouraging service mission? Clearly you would be. And so we're thinking as a system, could we have a 21-day leave on return at the Ohio State? We actually have that as a policy, and we're currently thinking, can it be paid or unpaid? Could we even pool sick time or something like this, so we can still encourage service missions, but also deal with the at least perceived risk to patients in contracting. So beyond quarantine of healthcare workers, quarantine of the public is a societal question. So those exposed to an infected person or with travel to a risk area, can air travel be limited? Well, the unintended consequences and challenges of that have been highlighted by media, government, and other health organizations, one of which is that it may encourage people to lie or be subversive. Much better to know that they're coming from a reason, but there are several other economic and other impacts that I won't go into detail. There is a challenge in identification and reporting in the general public. There's a challenge of identification and reporting in healthcare workers, too. It's how do you know where your employees have gone. And then there will be, anytime we bring up quarantine, there will be a robust debate over civil liberties versus public health interests. This was true in the SARS outbreaks in China, even the small one in Canada. The quarantine was very effective, but may have been overutilized, the critics would say. And in the U.S., we have history with measles quarantines and tuberculosis quarantines. A quick word on isolation versus quarantine. Isolation is isolating a patient with disease. Quarantine is isolating someone with exposure without manifestation of disease yet. So the contagiousness is a main factor, but I think the mortality is a factor as well. So that Ebola is not overwhelmingly contagious, especially with early disease exposure. That's not, I don't think, is a convincing argument, given that if you do contract it, the mortality rate is so high. So another quandary that can arise is the use of unapproved or experimental treatments. In a rare disease, innovation's needed. We often don't have time to have large sample size randomized controlled trials, at least in one institution. So innovation may be needed. However, innovation is ideally still monitored in a research protocol, and review and patient protection still need to be a standard. So the long usual IRB review that can take up to weeks to months is not feasible in these cases, obviously. So having a fast-track IRB approval policy for Ebola, or having advance approval of known protocols as they become available. This would be clearly true if you're in Nebraska or at Emory. Multi-institutional approvals, so formation of networks for Ebola research and centralizing and streamlining rapid protocol review and approval can be helpful. But with all of this, we shouldn't just make things rapid. We should have periodic review as the dust settles, which right now we're in a area of calm. It's a good time to review what our best practices should be. So then there's this large question that's hitting the society on why is this happening in this day and age? Couldn't we treat Ebola? Couldn't we have a vaccine by now? Well, I think, and what's going to happen when in a year or 2 years or 6 months we have an effective vaccine or treatment? People will say, well, if this were a disease that sprung up in Europe or America, we wouldn't have these outbreaks and all these lives wouldn't have been lost. Well, that's probably true. So would this have happened if it weren't just an African disease? Probably not. So there's been a lot of calls for justice and these redistribution programs and proposals, such as taxation on popular pharmaceuticals in developed countries to help fund drugs and treatments and vaccines for diseases that largely hit the undeveloped world or the developing world. And the challenges with all these proposals is really it gets down to a basic understanding of the market. Is free market, or is the market an ideology, or is it a reality? So I hold that it's a reality, not just an ideology, and that all actions in a market will have unintended and intended and unintended effects. So there may be danger in these redistribution policies. Further, I don't know if we use justice if we know where the limitations are. Which diseases do we target? How many countries do we include? I don't know if that's a demand of justice or if it's a demand of charity. And unlike those who follow Rawls and say that charity should be a pejorative and a dirty word, I think charity, especially in a Christian context, is one of the virtues that we should hold fast to. So this Ebola outbreak does provide opportunities, although I wish it would may Ebola die a swift death and may we eradicate it. It does provide opportunities to enhance relationships and partnerships. In Central Ohio, we've really realized a really impressive group effort with all the health systems that are competitors on most things, but really working together on this. And perhaps it brings the possibility for us working together on other health concerns. So thanks again to the CBHD team. Thanks also to my colleagues at Ohio State that helped with the data for this presentation, and thank you for listening. I'll take your questions, or if you have better answers or answers at all, I'll entertain those. Thank you.
Well, thank you, Dr. Nash and Dr. Honorecker. For those of you who are interacting with the Center for the first time, we want to encourage you to visit our website at cbhd.org. In addition to the information about the Center and initiatives like the Healthcare Ethics Council, there are also a wealth of other resources, including case studies and articles exploring a wide range of ethical issues relevant to clinical practice. Additionally, we encourage you to join our free weekly or monthly email list to stay informed about updates from the Center, bioethics news, and future offerings like this webinar. And we also encourage you to consider becoming a member of CBHD. So on behalf of the Center for Bioethics and Human Dignity and the co-chairs of the Healthcare Ethics Council, I'd like to thank you for joining our webinar today, and we hope to connect with you again in the future.